Hello, thank you so much for joining me. Today, I will be presenting my policy brief titled Public Health Regulatory Framework for Psilocybin-Assisted Therapy in the United States. My presentation examines how current U.S. drug policies align with emerging scientific research on psilocybin-assisted therapy. Using a public health policy framework, I evaluate several policy options and propose a regulatory approach that could expand treatment options for individuals experiencing severe mental illness while also maintaining safeguards for patient safety and public health oversight. Mental health disorders represent one of the most pressing public health challenges in the United States today. Major depressive disorder alone affects more than 20 million adults each year and remains one of the leading causes of disability worldwide. In addition to its human impact, depression also creates significant economic costs. Recent research estimates that depression costs the U.S. economy approximately $326 billion annually due to the healthcare expenditures, lost productivity, and disability. These statistics highlight the importance of developing new and effective treatment options for individuals experiencing severe mental illness. Although several treatments do currently exist for depression in particular, including antidepressant medications and psychotherapy, many patients do not respond adequately to either of these treatments. This condition is often referred to as treatment-resistant depression, which occurs when individuals do not experience sufficient improvement after multiple treatment attempts, oftentimes over many years. As a result, a substantial portion of patients continue to experience severe symptoms despite receiving conventional treatment. This treatment gap has led researchers to explore alternative therapeutic approaches that may help individuals who have not responded to existing treatments. One area of increasing scientific interest is psychedelic-assisted therapy, particularly the use of psilocybin in structured clinical settings. Psilocybin is a naturally occurring psychedelic compound that has been studied in several controlled clinical trials. Research has shown that psilocybin-assisted therapy may significantly reduce depressive symptoms, particularly among individuals with that treatment-resistant depression. Many studies have also reported rapid and sustained improvements in psychological well-being following treatment. Because of these promising findings, the USDA has granted breakthrough therapy designation to psilocybin-based therapies for depression, which does help accelerate the research and development process for promising treatments. Despite emerging scientific evidence supporting the therapeutic potential of psilocybin-assisted therapy, the current U.S. drug scheduling policies remain largely unchanged. My policy brief argues that current federal drug policies are increasingly misaligned with the modern scientific research. A regulated clinical framework allowing supervised psilocybin-assisted therapy could better balance innovation in mental health treatment with appropriate safeguards for patient safety and public health. Currently, psilocybin is classified as a Schedule I substance under the Controlled Substances Act. Schedule I drugs are defined as substances that have a high potential for abuse and no accepted medical use, which we know is not true for psilocybin. This classification places strict limitations on both research and therapeutic use. So as a result, researchers must navigate complex regulatory barriers when conducting clinical trials, and patients cannot access psilocybin-assisted therapy outside of the limited research settings. I wanted to throw this in here because ketamine has been an emerging treatment as well and can be kind of compared to the path of medical marijuana and how I view psilocybin kind of following in that same path as well. So ketamine is classified as a Schedule III drug and is currently used in clinical settings to treat severe depression as well as chronic pain. Ketamine infusion clinics have emerged across the U.S. where treatments are administered under medical supervision. Additionally, the FDA has approved a ketamine-derived medication called esketamine for treatment-resistant depression in particular. So although ketamine and psilocybin are pharmacologically different, ketamine therapy demonstrates that altered state psychiatric treatments can be integrated into healthcare systems when appropriately regulatory frameworks are established. So overall, this situation creates tension between what is federally legal or illegal and what is new in the emerging research that has been shown to work for treatment-resistant depression in particular. So on one hand, scientific evidence supports psychedelic-assisted therapies, and that continues to grow. But on the other hand, federal prohibition under the Controlled Substances Act remains unchanged. Nothing has changed. It is still a Schedule I drug. So at the same time, some states have begun experimenting with alternative regulatory approaches. And for this example, I want to cite Oregon. They established the first regulated psilocybin service program in the U.S., following supervised administration of psilocybin in licensed facilities. These developments highlight the growing gap between the emerging research and the existing federal drug policy. So, from an epidemiological perspective, major depressive disorder represents a significant public health burden. Treatment-resistant depression represents a particularly serious challenge because individuals experiencing this condition often have limited treatment options. It's kind of medication, therapy, both, or what? Nothing. Clinical trials studying psilocybin-assisted therapy have demonstrated promising outcomes, including reductions in depressive symptoms and improvements in overall psychological well-being. These findings suggest that psychedelic-assisted therapies may offer an important new treatment pathways for individuals experiencing severe mental illness, including treatment-resistant depression. Legal and economic factors also play an important role in this policy discussion. The current Schedule I classification of psilocybin significantly restricts both the research opportunities and the potential therapeutic use. At the same time, economic burden of depression in the United States is extremely high. Effective treatments that improve patient outcomes could potentially reduce long-term healthcare costs, improve productivity, and decrease the overall economic burden associated with mental illness. Political and ethical considerations are also important when evaluating psychedelic policy. Public perceptions of psychedelic substances have historically been influenced by stigma associated with illicit drug use and the war on drugs. Ethical considerations also include issues of course, equity and access. Emergent therapies may initially be available primarily through private clinics, which could limit access for lower-income populations, of course. Additionally, the principle of reciprocity, suggests that individuals suffering from severe mental illness should have access to potentially beneficial treatments when conventional therapies have failed. So, I have 3 policy interventions to discuss. The first policy intervention involves expanding federal support for psychedelic research while maintaining restrictions on therapeutic use. This approach would include increasing federal funding for clinical trials and streamlining regulatory pathways for researchers studying psychedelic therapies. While this option would improve the scientific evidence base, it would not immediately address the needs of the patients that could use it. The second intervention involves developing federal regulatory framework that allows supervised psilocybin-assisted therapies within licensed clinical environments, very similar to how ketamine is operating right now. Under this model, treatments would occur in regulated facilities with trained therapy facilitators, patient screening protocols, and federal oversight. This approach would allow policymakers to expand treatment options while maintaining strong safeguards for patient safety. And lastly, the third intervention involves reevaluating psilocybin's classification under the Controlled Substances Act. Rescheduling psilocybin could reduce the regulatory barriers to research and potentially allow medical use within healthcare systems. However, Rescheduling alone may lead to inconsistent oversight and varying clinical practices, which does raise concern about treatment standards and patient safety. There are several limitations that should be considered when evaluating psilocybin-assisted therapy as a public health intervention. First, research on psychedelic therapies is still evolving, and long-term outcomes require further study. Second, political resistance and social stigma surrounding psychedelic substances may slow down the regulatory reform and progress. And lastly, implementation challenges such as provider training, regulatory oversight, and equitable access will need to be addressed if a therapeutic framework is developed. So in conclusion, mental health disorders remain one of the most significant public health challenges in the United States. Emerging scientific evidence suggests that psychedelic assisted therapies do offer promising new treatment options for individuals who do not respond to existing treatments. Modernizing regulatory frameworks to allow carefully supervised therapeutic use could help policymakers responsibly integrate emerging mental health therapies while maintaining strong safeguards to protect public health. Thank you so much. Here are my resources, and I hope you learned a little bit today. Thanks so much.